So first off, as I said, there is a need and an opportunity here, and from everything that we've seen that happened in long-term care, an opportunity came up for the National Standards of Canada, or the NSC, to really look at trying to provide greater harmonization of long-term care services across Canada. And so what happened at that point is the NSC reached out and spoke to the Standards Council of Canada, the SCC. I apologize for all these acronyms in here, who then reached out to two groups. One of the groups was the Canadian Standards Association, or the CSA group, and the other one is the Health Standards Organization, or HSO. And I believe after me, you're actually going to hear from Dr. Samir Sinha, who works with the HSO. And the SCC asked our two organizations to work collaboratively to look at the development of two new national standards for long-term care that could really be looking at the issues that we've seen occur over the past 3 years, but more importantly, to be shaped by the needs of the residents, families, and Canada's long-term care force itself, and specifically take a resident or person-centered approach. So first of all, very quickly, what are standards? Because you're going to obviously hear about them today from me, and then from later on from Dr. Sinha. Standards are really everywhere, and they exist in every aspect of our life. And they tend to be what we like to call the invisible infrastructure that allows us to live and work safely and thrive, and really can become the basis of government legislation, policy, regulations, and accreditation standards. Now, the one thing I'll say right off the bat here is the standard being developed by CSA is not legislated or is not part of policy as of yet. It is a voluntary standard that we are developing, as we typically do at CSA. But obviously, we hope that there will be something done by the government moving forward. Now, really, to truly understand what CSA does and what a standard is, the example I always give is, look on the back of your bike helmet, or look on the back of your ice skating helmet, and you're going to see a sticker that says CSA. That is the mark of approval that there's a standard that basically regulates those types of products. And we're trying to do the exact same thing here around long-term care homes. So I don't think I need to spend a lot of time on this slide. Why are long-term care standards needed? We all know what's happening in our country and around the world. But 58% of all Canadian COVID-19 related deaths occurred in long-term care and retirement homes. We are actually one of the worst countries in the world with respect to the number of deaths that's happened in long-term care homes, according to the OECD. And so because of that, the federal government has committed to working with the provinces and territories to try to set these new national standards for long-term care. And this came out in their 2020 throne speech and mandate letters to the ministers of health and seniors. And in addition, we all may remember that in the budget 2021, the federal government committed $3 billion to support the implementation of new national standards in long-term care. So based on this commitment from the federal government, HSO and the CSA group, we submitted proposals to the Standards Council of Canada to develop these two new complementary standards working together. And obviously this was accepted, and we are funded to do that. Now, just a quick note on the $3 billion, because I always get asked this. We still don't know what the government is spending the $3 billion on, and this is something that we're going to continue to work on to understand. So in terms of the concept of this new standard, which officially is called Z8004, and I'll talk more about that, our standard focuses really on three main aspects around long-term care: safe operating practices, infection prevention and control practices, and design. And the whole topic around cleaning and disinfecting, waste removal, HVAC, or heating, ventilation, and air conditioning, plumbing, medical gas system, et cetera, are part of the standard and are informed by the standard as well. Essentially, you can think that our standard is really trying to outline how to develop and design a safe, environment and a safe infrastructure for people to live and work in when it comes to long-term care. Now, what our topic does not include or is out of scope is anything around administration requirements, medical practices, professional obligations, and more importantly, we do not address anything around resident care and delivery of services. This is what the HSO standard is about. But as you can imagine, we have to work very, very closely, because if the HSO standard, as you'll hear about after me from Dr. Sinha, is talking about the number of residents that are supposed to be in a room or some of the care practices that should be provided, our standard at CSA needs to make sure that we're providing an infrastructure and an environment that can support those care practices. So whenever myself and Dr. Sinha talk about these things together, which has been a lot over the past 3 years, we really try to describe that the CSA standard that I worked on and developed with my committee, and I'll talk about here, is really the hardware, while the HSO standard is kind of the software. Now, typically a CSA standard is very, very technical and is written in using technical language and jargon that typically only engineers, designs, and architects understand and use. This standard is different, though, as you can imagine, because this standard is going to most likely also be read and very closely followed, not just by those designing the environments, but by those using the environments as well. And so that's the residents, the families, the care workers, the staff, the management, et cetera. So we want to take a very different approach in the development of this standard and ensure that we are not using specialized jargon. We want to make sure that the language in there was going to be universal, and that also was cross-cutting across our country, coast to coast to coast, including different cultural aspects, et cetera. And again, I'll talk more about that in a few moments. So one thing I just want to mention is CSA is not brand new to the healthcare game. They've developed actually many, many standards that relate to healthcare, and a lot of them are listed here. And so our new standard, CSA Z8004, refer to many of these standards, but again, was developed as a brand new standalone version. And the reason for that is because long-term care homes are exactly that. They're people's homes. They are most likely the last home that many of the residents will live in. And so we didn't want to design them as healthcare facilities. While some healthcare obviously is being provided in these homes, again, we want to make sure that we moved away from healthcare practices and healthcare facility engineering standards, which are very technical, and ensure that we took into account that these are people's homes and therefore should be designed as such. So in terms of the process of developing the standard, the first thing we do is we put an open call to all Canadians to submit a short application to be part of our technical subcommittee. From that, we selected 29 members, and that was chosen from over 100 applications that we received. In our technical subcommittee, our 29 individuals represent 8 provinces and territories, multiple national organizations, and we want to make sure that we had also a balanced representation of general interest, user management, education, government, et cetera. Now, because we want to make sure that we had the voices of the residents and the families themselves, and that this was resident focused, we also then had to develop 2 additional working groups that supported the work of this technical subcommittee. And that was a resident and family-centered care working group, which actually included members who were residents in long-term care homes, their family members, and also some staff members. And we also had a government advisory table where we invited every province and territory to send a representative. The majority did. Unfortunately, right away, we did receive some calls from ministers of health and long-term care for a couple of our provinces who basically said, sorry, we're not going to engage. And that's fine. We'll get them eventually, is my opinion here. The process in terms of development cycle, we started March 2021. Here are the steps and the various timelines of what we want to do. Typically, a standard takes 2 to 3 years to complete. We had to do this one in 21 months, and we're still going. So we had a very, very aggressive timeline. And as you can imagine, this is absolutely needed because we needed these standards 5 years ago, not right now. And so we're trying our hardest to get these standards out as quickly as possible. And as you see here, hopefully by the end of this calendar year, as I'll talk about in a few moments. This process also involved public engagement, and this was something new for CSA as well, that I really want to ensure that we are hearing the voices of all the key stakeholders that would have an interest in this particular standard. And so we did several activities. So the first thing we did is we had some national surveys that went out early on. We had 3 focus surveys, one on residents, families, and caregivers, one for long-term care management administration, and then one specifically on equity, diversity, inclusion. And the whole notion of EDI was critical and was at the center of this entire standard itself. And as you'll see in a moment, we actually have a section on EDI itself. We also then held various group consultations using Zoom at that time because we still were not able to meet in person. And again, we targeted facilitated discussions that were designed to reach specific groups. And this included, again, frontline workers. We had some fascinating consultation with Indigenous communities, as well with 2SLGBTQI plus groups and communities. And then obviously with older adults themselves and long-term care home operators. Now, from all that information, I'll skip down to number 4 very quickly. We actually then generated 7 reports called What We Heard reports based on all of this information. And I can send the links to these reports to you after the presentation so you all have them. And this basically summarizes all the information from the surveys, from the group consultations, et cetera. Item number 3, we also then had a public review period of our draft, and this is mandatory by CSA. And this was open for 60 days, which just closed this past March. And I'll talk a little bit more about this in detail in a few moments. So in terms of the standard itself and some key highlights, CSA uses the terminology clause, which essentially is a chapter. And each clause then has many, many subclauses. I think total we had somewhere around 700 or actually close to 1,000 clauses and subclauses in our standard. So it's a very, very large standard. And you see the main headings here. I just want to highlight a few of them, which I think are really important and really innovative in the development of such a standard. The first one is clause 4, organizational commitments. So right up front, we laid out specific things that we want organizations, that is long-term care home organizations, to commit to moving forward. And that includes things around equity, diversity, inclusion. It includes things around cultural preferences that need to be included in any operational aspects of the homes themselves. And in fact, we go as far to include things around sexuality and sexual choice and preference of the residents and how those must be respected as well. Clause 5 was, your standard things around operations. We wanted to make sure we included aspects around quality improvement and quality control. And in fact, our standard even includes in the annex examples of quality control tools that long-term care homes can use. Obviously, infection prevention control, or IPAC, was the heart of the standard itself. Clause 8 design, again, was something that it was new to CSA. Typically, CSA does not talk about the design of the facilities or design of whatever the standard is about. But we are insistent that, again, the back-end systems and infection prevention and control, et cetera, must go hand in hand with design. So we include sections around design of resident rooms, design of hallways, design of the meal areas, and again, take into account things such as cultural preference, changes in cognition, changes in physical capabilities of older people, but also then the safety of the staff as well. So that's really critical. Clause 10, something again that's innovative in this standard, in my opinion. We have a whole section around the types of infrastructure that's required in order to put in information and technology and communication devices and systems. So we do not prescribe here the types of technologies that must be used, but we say the infrastructure that's required. And so this includes anything from patient management systems that will make the workflow of the staff easier, medication management technologies, but also includes things in the future. So we talk about the infrastructure that's required to have wearable sensors and to use things such as robotics, whether service robots or personal robots, and then even things like artificial intelligence, machine learning, et cetera. So we really try to have a future look in the standard itself. Now, the final thing you'll notice here is this diagram here, because this was something that was, again, always at top of mind as we went through this. We had to balance properly infection prevention control and the safety of the residents and the staff and the family members and visitors, again, with this whole notion of ensuring the autonomy and dignity of the residents themselves. And when we came into this, we were very adamant as a group that it's not going to be one or the other, that we can have both in a standard, and hopefully we've achieved that. Now, in terms of the public review period, we had a wide range of people over the 60 days provide comments. Again, you'll see your typical things such as architects and engineers, but we also had caregivers, we had care provider organizations, disability organizations, family councils, and as well as researchers from various universities and older adults themselves all provide feedback and comments on our standard. In terms of the public review feedback information that we received 1,700 comments from 600 individuals over a 60-day period. But to put this in perspective, typically a CSA standard receives maybe about 100 comments on it. So, the fact that we had so many comments and so many individuals engage and actually review the standard during the review period was just testament, I think, to the importance of the work we're doing and how engaged the public is around this. And this pie graph here just shows the type of comments that were being provided, the majority of them just being general comments, followed by technical feedback and then editorial comments. I apologize, this graph is very small, but in terms of the areas and the sections that were commented on, the majority of feedback was provided in the infection prevention control feedback section, followed by the operations and the design. But you can see here as well that obviously feedback was provided in other sections as well, including the information technology section, catastrophic event management training, et cetera. Now, I just want to also provide some quotes here that were provided in our comments, and obviously these are biased. I selected all the ones that are all telling us how great our work was. And the reason for this is not only because I was chairing the group and I like to see positive feedback, but it was also that the majority of the quotes and the feedback received were very, very positive. And all the feedback we received was very constructive, which was fantastic to see. So some key quotes here: the standard and its provisions are an important step in acknowledging the lessons from the pandemic. So it's good that we were acknowledged for that. Members were heartened to see a resident-centered focus throughout the proposed standard. So again, as I mentioned, the notion of being resident-centered or person-centered was key throughout all of our work. So I'm glad that was recognized and seen in what we're doing. The emphasis in the CSA draft standards on communication and relationship building is heartening and a significant leap forward, making person-centered care and quality of life a reality for long-term care residents. Personally, I love this quote because, again, we try to get CSA to do something different than what they typically do, and they accepted that and they allowed us to do it. And I think that was reflected in this particular quote, where the standard is all not just about technical aspects of the operations of the home, but also include these aspects around relationship building, the importance of the relationship between the residents, the staff, the family members, and the facility itself. Equity, diversity, inclusion. Nice to see this is included. Again, something that we want to do. And this final quote is again also kind of special to me, just because my area of research is in technology and aging here at the University of Toronto. And in AgeWell, internet access is essential and missing in most homes. Families use their own data plans to facilitate access to other family members or to provide activities for the residents, such as using streaming audio or video services. Glad to see this is part of the standard. So this is really critical because, we saw a lot of news stories about how social isolation became one of the, the top factors in the poor health and quality of life that our seniors face in long-term care homes. And just having something as simple as access to the internet, access to a tablet, and some simple training provided to the residents could have overcome some of these significant gaps that we saw. So again, I'm glad it was recognized that this was in our particular standard. So finally, just to go back, we are on time. We are on track, I'm happy to say. So the final production of this standard in English and in French will be made public by the end of this calendar year. Typically, a CSA standard can cost anywhere from $500 to $2,000 for someone to purchase to read. Again, we pushed CSA to do something different here, and they accepted it. This standard will be made freely available to anyone who wishes to download it and have a copy of it for the life of the standard itself. And again, this is a big change in the standards world. And again, just testament, I think, to everyone recognizing how important the standard is and how important this topic is. And with that, I'd like to thank you for the time to present this. I hope after you see, I think it's an interview with Dr. Samir Sinha, you'll see how we've worked very closely together. Here's my contact information. Feel free to reach out to me with any questions or comments you may have. Also, if you are on social media, here is my Twitter handle, where I tend to put out a lot of information and updates about the standard. So feel free to follow me there. And also take a look at AgeWell in general. AgeWell is a national organization representing researchers right to seniors and caregivers in terms of the development and the translation of new solutions, including technology, policy, and practice to support older adults to live in their own homes and communities as independently and as happy as possible. And with that, I will stop sharing my screen and hand it back to Gloria.
We actually have a couple of minutes that we could have you answer a few questions. So if people want to put their questions into the chat, they can do it now. And it was interesting, Alex, to see the process that you went through and the extent of the consultations. It was much more than I had imagined would take place. Also, the fact that you were getting into some of the operations as opposed to just the infrastructure. And what many of us understand as infrastructure, which is the heating, the ventilation, the various things that go with infection control.
Yeah, to answer your first question or your comment around the level of consultation, again, this was something new that we really pushed, that we need to have this level of consultation. We need to be completely transparent in the development of both standards, as you'll probably hear from Dr. Sinha as well. And so we continue to do that. The other thing I'll mention is we are also committed and just received additional funding from the government to continue to do consultations and educational sessions once the standard is released. And so we want to work directly with the communities, with the long-term care home operators, et cetera, for them to understand how they can implement the standard and the best ways of doing that. So we are committed to continue this beyond December as well.
We have a question from Jamie Borisoff at BCIT, who wanted to know if there's any tension between your standards and the provincial or the municipal building codes.
The simple answer is yes. There was a lot of tension throughout this process. But what we did and what we realized very early on is we're not here to override or supersede any building codes that may exist provincially, municipally, et cetera. And so where there are those types of building codes or standards already in place, we try to refer to them as much as possible in our standard. And so we will have standard clauses throughout the entire document that says for this particular aspect or particular topic, please refer to your local building codes and standards for that. And so again, we want to make sure that we're not just seen here as kind of this big thing that's coming in trying to take over everything, but really ensuring that we complement what's already been done and what's already out there.
Okay, there's a question from Andrew Wister about federal, provincial, territorial challenges to your group.
Yeah, so this is again another tension. As I mentioned, we had a couple provinces right off the bat say, sorry, we're not going to sit around the table and listen to this. We're doing our own things. We had purposely, we did not include any representation from the federal government around that table because, again, we want to make sure that the provinces and territories felt that they are owning this with us and that this is not just a federal government thing trying to push things down from the very top, but this is very much a bottom-up approach. And so we try to, overcome those challenges that typically you would see between the federal government and the provinces and the territories by doing those various kind of small things in there and ensuring, again, that we are completely transparent with the provinces and territories. Even with those that are not sitting around the table, we still send information to them, whether they read it or not, I'm not sure. But yeah, absolutely, there are tensions and there are going to be ongoing challenges as this gets implemented as well. And we're just going to take those on kind of one step at a time.
There was a question, could you say a little bit about the design cultural aspects and cognitive aspects and attention considerations for the employees?
Yeah. So let me start with the design aspect from a cultural perspective. So for example, when we met with Indigenous communities and Indigenous leaders, we learned things such as the importance of meals and the importance of their culture of preparing their meals, preparing traditional foods as part of those meals, and sharing meals with their families and their friends and others. Long-term care homes right now are not set up to do that. They're not allowed to, share meals like that, to have kind of large gatherings, et cetera, especially if there's something going on in terms of an influenza breakout or, God forbid, another pandemic down the road. So we took that into account into some of our design aspects, that how can we design a facility that would allow those cultural practices still to happen, which again are not unique to just Indigenous communities, obviously. Other cultures have their own practices when it comes to mealtime, et cetera. And so we want to make sure that we had design in there that allowed for these practices to happen, and that in the case of something happening, that again, these practices could continue in some way in a safe manner. So that was the cultural part. What was the other aspect?
The other was
the cognitive aspect.
Yeah.
Yeah. So there we took a lot of research and best practices from researchers here in Canada doing work around care home facility design and people with cognitive impairments such as dementia. But we also took best practices from around the world as well. So we looked at the Dutch programs, obviously, others in Europe, in Asia, and we tried to incorporate kind of the best in our designs. So for example, the design of circulation pathways so that there could be positive wandering by people by dementia, and that we're not, restricting them from that wandering behavior, because in fact, it could actually be positive in some manners. We included the design of gardens and outdoor spaces in the standard as well, because obviously looking at programs on gardening and the positive impact it has on on people with cognitive impairments, but even individuals who may not have cognitive impairments, but again, who may have agitation or other aggressive behaviors, that how those types of activities can really help and be very calming. So again, we took all those types of practices and we try to put them into the standard. Now, the one thing I'll mention is if it's not in the standard itself, it's then in the annexes, because there's some things that we're not allowed to be in the standard because of the way that the standard is written and approved upon by the CSA group. So we were allowed to put those things in the annexes as well. And we're also going to be producing more papers and documents that can be seen as accompanying the standard as well.
Okay, there's a question that's phrased as, has any research been conducted in northern BC? I presume what the questioner is wanting to know is whether the standards take into consideration some of the geographic differences.
Yeah, absolutely. And that was really critical for us. So we did have experts on the panel on our committee that were from the north. We work closely with the group at University of Northern British Columbia that does a lot of work around this particular topic in the north. Then obviously through all of our consultations, we also try to take into account, again, what aspects around design and infrastructure would work no matter the geography. And it's just not in the north. You know, there are small communities throughout Canada that do not have the resources that may be required to implement these standards appropriately. And so we had to take that into account. The other thing I'll just add to that is the other kind of big tension was new builds versus current homes. We had to develop a standard that would work for a home that may be 30 or 40 years old, or work for, you know, a brand new home that's currently being built. And so that was actually a really tough tension and a tough line for us to walk. But I think, we didn't solve it, but we did our best, I would say.
Okay, we need to move on, but I have one more quick question, and which I think many people have in their mind, and that is the standards are complied with on a voluntary basis by the different facilities. How do we convey the message that we as a public would like to see those standards in fact achieved?
And Gloria, that's exactly the approach we need to take. I don't think relying on the government to legislate this is the way to go right now. Whether they do that or not is going to be their decision. But this needs to be a ground up, bottom up approach that, you know, we need people to say that these standards are important. We need the care home operators to understand the importance of them. And that is why we did such amazing work in terms of talking to older adults, talking to residents, talking to caregivers, family members, and really to get their buy-in. And the hope is that when we go to a long-term care home operator and say, well, here's the standard, they're going to look at it and say, well, yeah, this absolutely makes sense for us to implement, and we see how we can implement it. We're not expecting 100% of the standard to be implemented. That'll never happen. But our goal is to work with these home operators and municipalities, et cetera, to show how they can implement as much as possible in order to at least raise their level to the point that we don't see happen ever again what we saw over the past 2 to 3 years.
Yeah, because I think a lot of people are under the misapprehension that the standards are law.
Yeah, exactly. And that's not the case, unfortunately. And it's different with the HSO standards because those are already part of the accreditation process in Ontario and Quebec, as you'll hear probably about from Dr. Sinha. So ours is a bit different, but Gloria, for all those out there, Gloria was my postdoc supervisor, and she taught me, don't do anything that's really not going to have an impact at the end of the day. So when I signed up for this, I said, well, I'm not doing this to see this thing sit on the shelf and collect dust. So I'm making sure we're putting the right mechanisms in place, hopefully to see as much adoption as possible across the country.
Well, thank you very much. You really set the stage for us. And given some information that I think we really, as advocates, needed to know.
Absolutely.